Your tongue is one of the easiest places to look for clues about your health, and sometimes a small change you notice in the mirror is the first sign that something else is going on. I'm Dr. Elena Morales, an oral medicine physician, and over the next few minutes, I'm going to walk you through 10 tongue findings you can spot at home, what they commonly mean, and when you should seek care. Stay with me until the end. There's one particular tongue warning that we need to talk about more carefully. If this is helpful, tap like and subscribe so you don't miss future practical guides about symptoms that matter. Quick note before we begin. Everything I say here is informational only and not a substitute for a professional evaluation. If you're worried, please consult a healthcare provider. Sign 10, Geographic tongue. You might see smooth, irregular, map-like patches of red on the surface of the tongue surrounded by pale borders. They can shift location from day to day, and while they can look dramatic, they're usually harmless. We call this geographic tongue because the red areas form patterns like little islands on a map. People often report a mild burning sensation with spicy foods, but most have no major symptoms. Common causes or associations include benign inflammatory reactions, and, less commonly, links with psoriasis or reactive changes after local irritation. My advice, if the patches bother you, avoid strong irritants, very spicy or acidic foods, and keep oral hygiene simple and gentle. A soft toothbrush, avoiding tobacco, and staying hydrated often reduce discomfort. See your dentist or primary care clinician if the pattern is new, painful, or accompanied by other symptoms like unexplained weight loss or swollen lymph nodes, because persistent changes always warrant evaluation. Sign 9, hairy tongue. Despite the name, you're not sprouting hairs. What you may notice is a dark, furry-looking coating along the midline of the tongue, often brown or black in color. This happens when the tiny surface projections on the tongue, called papillae, grow longer and trap bacteria, food pigments, or debris. It can smell unpleasant and look alarming in the mirror. Hairy tongue is typically linked to things like smoking, heavy coffee or tea drinking, poor oral hygiene, or recent antibiotics that disrupt the mouth's normal bacteria. The good news is it's usually benign. Practical steps: gently brush or scrape the tongue with a soft toothbrush or a tongue scraper after brushing your teeth. Reduce tobacco and excessive coffee, and talk to your dentist about whether a recent antibiotic course could be a trigger. If the discoloration doesn't improve with these measures, or if you notice bleeding, severe pain, or a fixed lump beneath the coating, get checked. Those findings are less typical for simple hairy tongue. I remember a patient, a 52-year-old graphic designer who came in convinced he had an infection because his tongue looked like a bad tea stain. He'd been on antibiotics for sinusitis and smoked half a pack a day. A few weeks of improved oral hygiene and quitting cigarettes cleared it up and his anxiety along with it. Type marks in the comments if you've ever noticed something like this on your tongue. Sign 8, smooth, glossy, red tongue, atrophic glossitis. When the surface papillae thin out, the tongue can look smooth, shiny, and unusually red. This can come with a burning or sore sensation and makes the tongue appear almost raw. In adults, this pattern can be a clue to nutritional deficiencies, particularly vitamin B12, folate, or iron deficiency, and sometimes to changes after long-standing irritation. If you see a smooth, red tongue, consider whether you have risk factors: a strict vegan or vegetarian diet without supplementation, a history of gastrointestinal conditions that impair absorption, like celiac disease, or medications that can affect nutrition. Practical steps include scheduling a visit with your provider to check basic blood work. Common tests include a complete blood count and evaluation of B12 and iron levels, and addressing dietary gaps with a dietitian or clinician. Avoid self-prescribing supplements without guidance, as interpretation of blood tests can be subtle and treatment individualized. Sign number 7, fissured tongue. Cracks or grooves on the tongue surface are quite common and often harmless. A fissured tongue may deepen over time and trap food debris in the crevices, which can occasionally lead to bad breath or mild soreness, especially if you scrub too aggressively. Fissuring is frequently congenital or associated with benign conditions like geographic tongue or with systemic conditions such as Sjogren's syndrome. I advise gentle cleaning after meals, a rinse and gentle brushing, and attention to oral hydration. If fissures become painful, show pus, or are accompanied by dry mouth, a dental or medical review is reasonable to rule out an underlying condition. Sign number 6. White coatings and patches know when it scrapes off. A white coating that wipes away easily with gentle scraping often points to oral thrush, a yeast overgrowth caused by candida. It's common with inhaled steroids, recent antibiotics, diabetes, or immunosuppression. Thrush may leave a raw red surface underneath and cause a cottony mouth feeling. By contrast, white patches that cannot be scraped off may represent other conditions, such as leukoplakia, which can arise from chronic irritation, tobacco, denture rubbing, and, in a minority of cases, contain precancerous changes. This is where patient history matters. Are you a smoker, a heavy drinker, or have you had a patch that's there for weeks without improvement? Practical guidance. If a white coating appears suddenly and you have a clear trigger like recent antibiotics or steroid inhaler use, a dental check and simple measures, rinsing, oral hygiene, evaluation for inhaler technique are reasonable first steps. However, any persistent white or mixed white-red patch that fails to resolve after 2 weeks should prompt evaluation by a dentist or oral medicine specialist. Further testing and sometimes a biopsy may be needed.
To rule out pre-malignant changes, don't ignore a persistent patch. Type APHTUS below if you've had recurring mouth ulcers. I'll cover those next. Sign 5. Recurrent painful ulcers. APHTUS stomatitis versus concerning lesions. Small, shallow, painful ulcers that come and go are commonly APHTUS ulcers, canker sores. They often recur, are linked to stress or minor trauma, and typically heal within 1 to 2 weeks. They're uncomfortable but not dangerous. A red flag is an ulcer that is persistent, more than 2 weeks, growing, firm to touch, or associated with a persistent lump in the neck. These features may suggest something more serious, including cancer, especially in people with risk factors like tobacco, heavy alcohol use, or HPV exposure. If you or someone you care for has an ulcer that won't heal, or if there's increasing pain, bleeding, or numbness in the tongue or mouth, book an urgent evaluation. Your clinician may need to examine the lesion closely and consider a biopsy. One of my patients, a 60-year-old former smoker, dismissed a small ulcer as a poker burn for 3 weeks before coming in. On exam, we found a firm base, and he was referred promptly. The lesion turned out to be an early squamous cell carcinoma. Early detection made a big difference in his treatment options. Sign 4. Strawberry tongue. When fever and red bumps are part of a pattern. Strawberry tongue describes a swollen, intensely red tongue with prominent papillae, resembling the surface of a strawberry. In children, this appearance alongside fever, rash, redness of the eyes, or swollen glands can be a sign of serious illnesses such as Kawasaki disease or scarlet fever. Kawasaki disease, in particular, is an inflammatory condition that can affect the heart and requires prompt pediatric care. If you see a child with a red, bumpy tongue and fever, seek pediatric evaluation immediately. This is not a wait-and-see finding. In adults, a similar appearance can occur with toxic shock or severe systemic illness and also merits urgent assessment. Sign 3. A non-healing ulcer or persistent lump. The cancer warning. This is the tongue change I want to emphasize because it's the one that most often aligns with the headline people worry about. A lesion on the tongue that is new, persistent, lasting more than 2 weeks, firm, ulcerated, or growing, especially if painless or with associated neck lymphadenopathy, can be a sign of oral squamous cell carcinoma. Risk factors that increase concern include tobacco use, heavy alcohol use, older age, and HPV exposure. Even without these risk factors, persistent, unexplained lesions should be checked. What to look for? A single spot that won't heal, an ulcer with rolled edges, a firm lump beneath the mucosa, or a patch that began as white or red and then developed an ulcer. The surface may bleed when irritated, and there can be referred pain or numbness. Importantly, early lesions may be small and not very painful, which is why paying attention is crucial. Action steps are clear. If you notice a lesion that does not improve after 2 weeks of self-care, see your dentist or primary care clinician for an exam, and ask for a referral to an oral medicine specialist or ENT if the lesion is suspicious. A specialist may recommend imaging or a biopsy to determine what it is. Early diagnosis substantially widens treatment options. Conversely, delays allow cancers to grow and invade deeper tissues. I always encourage prompt evaluation rather than assuming it's nothing. A clinical example. A 47-year-old teacher came in with a small white patch on the side of his tongue he'd lived with for months. He had quit smoking years earlier and felt fine otherwise. Because it hadn't cleared, we biopsied it. The pathology showed dysplasia, an early precancerous change. We treated it while the lesion was still localized. That case is why I stress the 2-week rule. Persistent changes deserve a professional look. If you've seen an unusual ulcer or bump, write check below and tell us how long it's been there. This community exchange helps others feel less alone, though of course it's not a substitute for a physical exam. Sign 2. Sudden swelling, angioedema, and airway risk. A rapidly enlarging, tense swelling of the tongue is an emergency. Angioedema can be allergic, medication-related, ACE inhibitors for instance, hereditary, or idiopathic, and it can progress quickly to obstruct the airway. Signs that require immediate action include rapid onset of tongue swelling, difficulty breathing, hoarseness, drooling, or inability to move the tongue. If you or someone near you develops sudden tongue swelling with breathing problems, call emergency services or go to the nearest emergency department immediately. Don't drive if breathing is compromised. This kind of swelling is not something to self-manage at home. I'll pause here in the narrative to pick up with the most consequential chronic enlargement in the next section, because it ties together several systemic conditions that often present with a visibly large tongue and subtle systemic signs. Sign 1. Chronic enlargement, macroglossia, and its meaning. When the tongue is persistently large, heavy, or fills the mouth, it is rarely a benign cosmetic issue. It is a clue to systemic processes that deserve careful evaluation. Macroglossia may develop slowly, years in some cases, or progress over weeks to months. The tempo and accompanying symptoms direct your differential. Common causes to consider: hypothyroidism, myxedema. Features include cold intolerance, weight gain, dry skin, hoarseness, slowed thinking. The tongue can feel thick and the speech muffled. Acromegaly, insidious growth in adults from excess growth hormone. Look for increased shoe or ring size, coarse facial features, excessive sweating, headaches, and snoring from obstructive sleep apnea. Amyloidosis. Protein deposition may thicken the tongue. Look for fatigue, edema, orthostatic symptoms, low blood pressure, proteinuria, or heart failure signs. Congenital and developmental causes. Down syndrome and certain mucopolysaccharidoses present in childhood with large tongue and delayed milestones. Vascular or lymphatic malformations. Hemangioma, lymphangioma, often asymmetric, present from childhood, may bleed or change with infection. Chronic inflammatory or infiltrative conditions, long-standing lymphedema, sarcoidosis, and rarely malignancy causing bulkiness. What to look for on exam: symmetry, diffuse versus focal mass, surface texture, smooth versus nodular versus fissured, firmness and mobility. Associated neck lymphadenopathy, signs of systemic disease, cardiac, renal, neurologic, and evidence of obstructive sleep apnea, snoring, daytime somnolence, morning headaches. Dentition changes, scalloping along the lateral tongue edges, and impaired swallowing or articulation. Initial workup and urgent flags. Start with history: onset, progression, systemic symptoms, family history, medications, ACE inhibitors, although more linked to angioedema, and prior surgeries. Tests to consider early: TSH and free T4, IGF-1 for suspected acromegaly, basic metabolic panel, urinalysis, protein, and referral for SPEP, UPP, and further hematology if amyloidosis suspected. Imaging: ultrasound or MRI of the tongue and neck for structural lesions, sleep study if OSA is suspected. Refer: ENT oral medicine for biopsy of focal masses or rapidly progressive enlargement, endocrinology for hormonal causes, cardiology/nephrology if systemic involvement is present. Management principles: treat the underlying disease where possible.
thyroid replacement, endocrine therapy for acromegaly, targeted therapy for amyloidosis. Address functional problems, speech therapy, dental/orthodontic planning, and surgical reduction when the tongue impairs breathing, swallowing, or oral competence. Be mindful of airway risk during anesthesia or sedation in patients with marked macroglossia. Inform anesthesia teams and plan for advanced airway management. A clinical note. An otherwise healthy 52-year-old man presented with years of progressive snoring and a heavy feeling in his mouth. Exam showed a diffusely enlarged tongue with scalloped edges and new-onset carpal tunnel symptoms. Elevated IGF-1 and pituitary MRI confirmed acromegaly. After endocrine treatment and selective surgery, his tongue bulk and sleep symptoms improved. If you or someone you care for have noticed a tongue that has been distinctly larger for weeks to months, write "look" below and how long it's been. It's worth sharing while you seek evaluation. Sign 2. Episodic enlargement, angioedema, and allergic patterns. When the tongue swells over minutes to hours and then subsides, think first of angioedema. Two mechanistic patterns matter for immediate management and future prevention. Histamine-mediated angioedema accompanies urticaria, pruritus, flushing, and often obvious allergic triggers, foods, insect stings, medications. It typically responds to intramuscular epinephrine in severe cases and to antihistamines and corticosteroids for ongoing control. If airway compromise is present, voice change, stridor, progressive dysphagia or dyspnea, call for advanced airway support without delay. Bradykinin-mediated angioedema, ACE inhibitor-associated or hereditary C1 esterase inhibitor deficiency, often lacks itch and hives. Onset may be more delayed after exposure to an ACE inhibitor, and swelling can be prolonged and recurrent. Familial patterns and attacks triggered by minor trauma or dental procedures suggest hereditary angioedema, HAE. For bradykinin-mediated attacks, epinephrine and antihistamines are usually ineffective. Targeted therapies, C1 inhibitor concentrate, icatibant, ecallantide, or long-term prophylaxis are indicated through specialty services. In all swelling events, prioritize airway assessment and early ENT/anesthesiology involvement for difficult intubation planning. Sign 3. Focal mass, distinguishing benign nodules from malignancy. A discrete lump on the tongue requires a deliberate differential. Common benign lesions, traumatic fibroma or irritation hyperplasia, smoother, firm, often at bite sites or along occlusal lines. Mucocele or ranula, floor of mouth, cystic, fluctuant, may transilluminate. Granular cell tumor, firm, slow-growing, often submucosal on the dorsal tongue. Vascular lesions, hemangioma tends to blanch, lymphangioma may have a pebbled surface. Papilloma and verruca, exophytic, cauliflower-like. Red flags for malignancy, most commonly squamous cell carcinoma on the lateral tongue. Ulcer or indurated plaque that does not heal within 2 weeks. A firm, fixed mass with tethering to underlying tissues. Pain at rest or referred otalgia, progressive dysphagia, or weight loss. Palpable, fixed cervical lymphadenopathy. Risk factors: tobacco, heavy alcohol use, older age, prior head and neck cancer, and immune suppression. Diagnostic steps for focal lesions. Inspect and palpate systematically: borders, base, mobility, surface changes, and relation to teeth and mandible. Photographing the lesion for comparison on follow-up can be helpful. For superficial, small lesions that appear benign and symptomatic, complete excision can be both diagnostic and therapeutic. For larger or suspicious lesions, perform an incisional biopsy with adequate depth to include submucosa. Mark orientation for the pathologist. Order imaging when depth, neurovascular involvement, or bone proximity is a concern. Contrast MRI for soft tissue characterization. Ultrasound for superficial vascular lesions. CT if mandible or extensive bony involvement is suspected. If malignancy is confirmed, staging with cross-sectional imaging and consideration of PET-CT per oncology protocols guides management. Chronic surface changes, glossitis, lichenoid disease, candidiasis. Diffuse surface abnormalities often point to inflammatory, infectious, or nutritional etiologies. Atrophic, smooth glossitis may reflect deficiencies, vitamin B12, folate, iron, riboflavin, or systemic disease. Ask about diet, gastrointestinal symptoms, chronic bleeding, and medication history. Geographic tongue, benign migratory glossitis, shows map-like erythematous patches with white borders. It is usually asymptomatic or mildly burning and requires reassurance and topical analgesics only. Median rhomboid glossitis and erythematous patches on the dorsum may indicate chronic candidiasis. Consider topical nystatin or systemic azole therapy depending on severity and host factors. Oral lichen planus presents with lacy white reticulations, Wickham stria, and sometimes erosive painful areas. Erosive disease often requires topical corticosteroids and regular surveillance because erosive lesions can mimic dysplasia. Leukoplakia, white plaques that cannot be rubbed off, is a premalignant sign. Biopsy any persistent focal leukoplakia, particularly if thick, nodular, or ulcerated. Tongue pain and burning syndromes. Not all tongue discomfort has an obvious lesion. Burning mouth syndrome is a neuropathic pain disorder, more common in middle-aged and postmenopausal women, often without visible mucosal changes. Management is multimodal. Address nutritional deficits, review medications for xerostomia-inducing agents, and consider neuropathic agents, gabapentin, low-dose tricyclics, in collaboration with pain specialists. Neuralgic pain from cranial nerve injury.
Or dental procedures may respond to anticonvulsants or topical agents. When pain localizes to an ulcer or mass, pursue biopsy to exclude malignancy. Taste disturbance and functional complaints. Changes in taste, dysgeusia, ageusia, or speech/swallowing require targeted evaluation. Examine the anterior 2/3 chorda tympani via facial nerve and posterior 1/3 glossopharyngeal nerve regions for lesions affecting taste receptors. Common reversible causes, medication effects, zinc deficiency, oral candidiasis, and post-infectious neuropathies. For persistent or progressive dysgeusia, check nutritional indices, zinc, B12, review medications, and refer for EMT/neurology if neuropathic causes are suspected. Airway and perioperative considerations. Patients with marked macroglossia, recurrent angioedema, or large base of tongue masses pose unique risks. Communicate clearly with anesthesia. Describe mouth opening, Malampity score, tongue bulk, neck mobility, and any known history of difficult intubation. In suspected obstructive sleep apnea related to tongue bulk, consider sleep study referral and coordinate with ENT and sleep medicine for continuous positive airway pressure (CPAP) trials or surgical options. For patients undergoing dental extractions or oropharyngeal procedures who have HAE or bradykinin angioedema history, ensure prophylactic strategies with appropriate specialists. When to biopsy and how to coordinate care. A low threshold for biopsy of persistent, unexplained, or suspicious lesions prevents delayed diagnosis. Biopsy any ulcer or plaque persisting beyond 2 weeks despite removal of obvious irritants and optimization of local care. For widespread mucosal disease, target the most representative area, erosive zone or indurated border. Coordinate with pathologists, provide clinical history, lesion duration, and prior treatments on the requisition. Use multidisciplinary clinics when available, ENT/head and neck surgery, oral medicine, oral and maxillofacial surgery, oncology, and speech-language pathology to plan definitive therapy and rehabilitation. Rehabilitation and long-term function. Tongue surgery, radiation, or chronic disease can impair speech, swallowing, and oral competence. Early referral to speech-language pathology preserves articulation and swallowing function. Therapy begins preoperatively when feasible and continues through recovery. Prosthetic devices, dental adjustments, and orthodontic planning may improve oral competence and dentition affected by tongue enlargement. Nutritional support and swallowing assessments prevent weight loss and aspiration in patients with significant dysphagia. Prevention and counseling. Some risk reduction is straightforward and impactful. Counsel tobacco cessation and alcohol moderation as primary cancer prevention measures. Emphasize good oral hygiene, regular dental care, and timely evaluation of new or persistent oral lesions. Review medications that may contribute to dryness, taste change, or angioedema. Coordinate alternatives with the prescribing clinician when appropriate. For hereditary angioedema or recurrent drug-induced angioedema, provide education on trigger avoidance, emergency plans, and the need for medical alert information. A brief clinical vignette that ties elements together. An otherwise healthy 67-year-old woman noted a small lateral tongue ulcer for 3 weeks. She initially attributed it to a bite from rough dentition. On exam, the lesion was indurated and fixed to the underlying tissue. There was a firm ipsilateral level 2 node. Incisional biopsy revealed squamous cell carcinoma. Staging MRI confirmed a 1.8 centimeter lesion.
She underwent partial glossectomy with sentinel node biopsy, followed by tailored speech and swallow therapy. Early detection allowed a single-stage curative approach and preserved acceptable function. Key takeaway points for practice: differentiate temporal patterns, rapid symmetric swelling, emergency angioedema algorithms, chronic diffuse enlargement, systemic workup, focal persistent lesions, biopsy. Never ignore a non-healing ulcer or an indurated mass of the tongue. Timely tissue diagnosis saves lives. Coordinate airway planning for patients with marked tongue bulk or history of recurrent swelling. Manage surface disorders by addressing local factors, treating infections, and correcting nutritional deficiencies. Use multidisciplinary care to preserve form and function after definitive treatment. If you have a specific clinical scenario, a persistent patch, an intermittent swelling, or a painful lump, describe the key features: duration, pain, associated systemic symptoms, medication history, and any prior biopsies, and the likely next steps can be outlined.